Hey there, if you have been curious about functional neurologic disorders and specifically functional seizures, and maybe the role that body awareness and interoception plays, you're not alone. I am equally obsessed, and that is the topic of today's discussion that I'm so excited to talk to you about. In fact, it's been a couple of weeks since I did a live because I was out camping, and I'm excited to come back. I've been reading a ton of literature, and I attended the Functional Neurologic Disorder Society meeting. I attended it virtually just a few weeks ago. One of the hot topics that really got my interest was interoception. And I am so excited to talk about this today. And particularly, I'm going to talk about this article. So let me just pull it up here. Heartbeat, evoked potentials, which I didn't even know what that was before I went to this conference and was reading some of the literature. Heartbeat, evoked potentials, and autonomic arousal during dissociative seizures, insights from electrophysiology and neuroimaging. There is so much packed into this article. I'm going to dive right in. And as usual, if you have questions, if you have comments, let's chat away here. I love hearing from you when we're doing these lives or afterwards. So I want to first, for those folks that maybe don't know what interoception is one of our sensations from the body. We typically think of sensations of things that we sense from outside the body, like sights and sounds and touches. But interoception is those sensations from inside the body. And that can include things like hunger. It can include sensations of needing to use the restroom. It includes sensations of our heartbeat and our blood pressure and our emotional world too. So all of those things are interoception. And there has been really interesting literature that has found that a person's interoceptive abilities may be linked to their development of a functional neurologic disorder. And I should say linked, we don't know cause, we don't know chicken or the egg, we know that they might be related. And so there at the FNDS meeting, there were several people talking about this in research, and in particularly with functional seizures. So this group and this particular article just came out, I believe it was published in June of 2024. So very, very recently, the first author, in fact, I'll bring it back up. It's a free full text article, by the way, and I'll put the link to the article and this video in our newsletter this week, as I do every week. So if you're not on our newsletter, join us. You can comment on this video newsletter. We'll send you the link. And the first author is Flasbeck, I think is how you say that. This group is out of Germany. So let me tell you what they did in this study. So they were very curious to look at this relationship of autonomic arousal and interoception in functional seizures. And Minnie Moo is saying, oh my goodness, I have all of these, so interesting. So I'm so glad that you're here. If you're like, yeah, this resonates with me, we're going to talk about how maybe these are related, and in particular, how these researchers are looking at the relationship. So they saw this can happen in functional seizures, which are also called dissociative seizures, by the way. And they did a retrospective analysis of data. So they had MRI imaging, they had EEG, they could look at heartbeat evoked potentials in folks with functional seizures. So here is what they did. So they did this retrospectively. They went through hundreds of patients and they found that they had the data to analyze on 24 patients. And I always feel like it's so helpful to know who are these 24 patients. These people had a mean age of 34 years old. They range from teens, so a 17-year-old to a 66-year-old. So there was a wide range of folks. They were majority female, so 17 of them female. And they had on average functional neurologic symptoms for 6 years. So these were not folks that were newly diagnosed. And they were folks that had seizures in a range of frequency. So some were daily, some weekly, some monthly, and even a person that was yearly. So they looked retrospectively at this data. So they had 24 people where they had the full data, and 16 of those people also had MRI imaging. And they wanted to look at MRI imaging so that they could look at how some of the symptoms and data might be related to imaging findings, which is cool because, and that's why this is called Insights from Electrophysiology and Neuroimaging, because they're looked at the EEG findings and the neuroimaging. Very cool. So that is the sample size. Now, I want to talk a little bit about this heartbeat evoked potential because I had never heard of it. And so I'm coming to you as the non-expert here. I'm a person that loves to read the literature. I'm the person that loves to go to courses and learn this stuff, but I'm not running a research lab. I'm not doing these things. So I want to show you a slide that was actually from the FND Society conference, and this was on these heartbeat evoked responses or evoked potentials. And these are, and this is what they talk about in the paper, these are understood to reflect what's happening in the brain in response to cardio signals. And so that's what you can kind of see on the picture on the left. It's a cardiac signal transmitted from the vagus nerve, interpreted by the brain. These signals show up on an EEG. So an EEG would be what a person might do if they have seizure activity, right? Because we want to see if it is epileptic seizure. So these heartbeat evoked potentials can be interpreted from an EEG. And, they talk about it in here. I'm not I think it's epileptologist. So I'm just going to put that right out there. They talk about how they actually interpret this. They look at the R spike of the heartbeat, and what is really kind of neat about this this physiologic test is that it doesn't rely on the person to interpret something or to follow some sort of testing protocol. It's literally measured in their brain. So it's very objective in that way. There are other ways that people look at measuring interoception. One of them is by counting and measuring your own heartbeat. And that's been used a lot in studies. However, that requires that the person can do and attend to that task, and not everybody can. So that's kind of one of the neat things about this heartbeat evoked potential. It's not related to a conscious perception of heartbeat. Very cool. They also found, they also kind of justify looking at this as a measure of interoception because the amplitude of the potentials change with alterations in interoception. So they're using this as a measurement of interoception. I think that's very interesting and just had never thought about it. So if you also had never heard of a heartbeat evoked potential, this has been, as I now have read about it and looked at it, has been done more often as a neurophysiologic marker of problematic interoception or aberrant interoception, and particularly during functional seizures. So there we go. And that one of the discussion parts of this paper, by the way, they said this could be a really helpful diagnostic tool also in functional seizures. So that wasn't the purpose of the paper, but there you go. So the other thing that they talked about and kind of the why and what they were looking at here is there are other studies that have looked at autonomic variables in functional seizures, particularly heart rate and heart rate variability, where they look to see if before the seizure or during the seizure and after the seizure, are there changes in autonomic arousal? Does heart rate go up? Does heart rate variability go down? And then is that correlated with this heartbeat evoked potential? Because if so, then it could show some sort of relationship between interoception difficulties and this autonomic arousal. So cool. Minimi was asking, can this also happen without seizures? So that is actually exactly where my brain went as well. This study was only done in functional seizures, but I actually was like, I wonder if this happens in tremor. I wonder if it happens with weakness. And actually, I really am very curious if this happens with functional paralysis, as part of that might also be a similar interoceptive or dissociative piece. Marcy Celeste French, what a beautiful name, is also said newly diagnosed with FND. Just want to say welcome. Symptoms for a lifetime. So Marcy, I just want to say that is not unusual, and that directly relates to this study too. I mean, they weren't looking at symptoms for a lifetime, but they're really looking to understand why. Why is this happening? What is the mechanism? And could it be that some of these interoceptive components, a person's ability to perceive and understand what is happening inside the body and the body state and the body's ability to maintain homeostasis, could that be underlying some of the functional neurologic disorder symptoms? Again, this is a small study. It's in functional seizures, but I think some of the themes really relate to other functional neurologic disorder symptoms. So, and what it seeks to answer, the question this study seeks to answer is, in people with functional seizures, this change in autonomic arousal, is it driven by an impairment in interoception? And they are using these measures to test it out. Heart rate and heart rate variability measures and the heartbeat evoked potential. So they're physiologically looking at this. I think this is really cool. So many people with functional neurologic disorders have been told they're making it up or it's in their head. And this is yet another study that is showing physiologic changes occurring. So I mentioned kind of who the patients are. And again, very, very small study. They were able to look at the EEGs and the MRIs of folks. And one of the things that they had to do is really go by when somebody's having a functional seizure, it's not clear on EEG. Nothing changes on the EEG. They have to go by the person's report of the onset or when they see it objectively in a video. So I wanted to kind of note that that's how they had to define when the seizure started so that they could look at pre-seizure, during the seizure and after the seizure, after the functional seizure. The other thing, anytime you go into a paper that is looking at autonomic activity and heart rate variability, they're going to break it down into several sub-measurements, I think you would say, of those. And so they're typically reported with these things like the SD of normal to normal intervals, or the SDNN. And this is the measure of the variability between normal heartbeats. And what's important about that, you don't need to memorize all of these things by any means, but this indicates your overall autonomic nervous system activity. So that's the SDNN. The other is the RMSSD, root mean square of the successive differences. So lots of math speak, to be honest. I do love me some math, but this is a measure of short-term variability in the heart rate. This is a direct measure of parasympathetic activity. So this is why, like, I can look at heart rate variability on my Apple Watch, but I'm not getting down into these pieces. We actually need EKG data to get some of these pieces. So they have that data. So they're looking at that data so they can look specifically at this autonomic and parasympathetic activity. So they looked at EEG, and then they looked at this EKG data with some of these scores and indices. So I just want to go back. I see some comments here. Marcy is sharing, I'm having episodes with severe tremors, increased breathing with tongue thrusting. Is that a functional seizure? Really great question, Marcy, that I could not answer on an Instagram live. But there are clear diagnostic criteria for functional seizures. And there are clear patterns that happen in the face and the body that only happen in functional seizures and don't happen in epileptic seizures. But the gold standard of diagnostic testing is an EEG. The EEG will definitively determine if you are having an epileptic seizure or a functional seizure. And most folks that I know who have been diagnosed with functional seizures have gone through the EEG testing. Now I say that, and even at the FND Society meeting, there are so many clear clinical diagnostic signs of functional seizures that you could get that diagnosis without the EEG. They are very clear, very, very clear differences in those. I'm not at the liberty, and I don't know. I'm also not a neurologist. I'm a neuro PT. I don't even know if I introduced myself because I got so excited about this, but this would be a good time to let you know I am not a neurologist. I'm a neurologic physical therapist. I run a program for people with functional neurologic disorders that is rehabilitation based. So we're not doing diagnostic testing. So thank you for that question. Ethnicity Gardens is saying agreed as well. Heart content. Are impairments in interoception just a lack of interoception, or can it be misreading bodily symptoms and overweighting them? What a beautiful question. And absolutely. So that's not this study, but those are things that again, when going to the FND Society meeting, that were talked about is how folks are actually understanding and interpreting interoceptive signals, and are they being interpreted correctly? So not just lack of interoception. Really great point. When all of this information comes into the brain and the body, or into the brain from the body, that's where those signals are. The brain really has to weight information. What's more important here? So, for example, if a lion is chasing me, my hunger, not so important anymore. My ability to activate and run away, very important, right? So the body is weighing all of these to keep or the brain is weighing all of these signals. So really good point the impairments or changes in interoception wouldn't necessarily just be a lack of interoception. It could be the weighting or interpretation of it. Ethnicity gardens is that makes sense. Sometimes your heart rate doesn't change while you are experiencing some symptoms. Yes, exactly. Or you don't even notice it, right? So that would be another piece. Really great point. Yeah, and Marcy says, thanks. I'll ask my movement neurologist and electrocardiologist. Yes, because Marcy, here's what I would say. One of the biggest pieces of F&D is sitting down with a neurologist and having them walk through why exactly do you meet the criteria for F&D versus another diagnosis. It's very positive, clear clinical criteria. Okay, now let's go back to the study. Great questions. And again, ask questions as we're going. I will come back to them. I'm just going to bring this back up here to reorient us. We're reviewing this study, which was so interesting. I was just going through the methodology where they looked at, or how they looked at the autonomic components, how they looked at the heartbeat evoked potentials. And then what they did is they actually took MRI images to look at cortical thickness to see if that was also related to some of the changes in interoception. And then, of course, they did a statistical analysis. So what did they find? One of the biggest pieces that they found was that the heart rate variability did change during the functional seizure. And particularly, they found that folks had a sympathetic arousal. And let's see if this even shows up. I have a table here from the study, and I think you can see it here. So this has the heart rate and then some of those heart rate variability. And then you can see on the side the t-test. And so you can see the heart rate changed from baseline to seizure. And then you can see the parasympathetic and the sympathetic indices as well below that. So those things changed during the seizure. That is in line with a lot of the other literature showing changes in sympathetic arousal with a seizure. What they found for heartbeat evoked potential. My sound. I'm so sorry. I think when I took the picture off, I hit the sound. Let me know if it's back up and I'll start back where I was. I'm so sorry. I took the picture down and I hit mute. It should be back on, so if you can give me a thumbs up, thank you. Thank you for hanging in there with me. So sorry about that. Sound went out because I hit mute because sometimes I'm clumsy with my fingers. So what I was saying is we were talking about the results, and I wanted to talk about the heartbeat evoked potential results. So they found that there was an increased sympathetic response during a seizure. For the heartbeat evoked potentials, they also found an increase in amplitude compared to baseline over particular electrodes. So I want to get those. It was the central and the right prefrontal electrodes. And I misspoke there. Not an increase, but a decrease. These were significantly less pronounced during seizures. What does that mean? So this would be interpreted to say that there is decreased cortex, so cerebral cortex, I feel like I got to get my brain model here for you all, decreased cortical activity. And in particular, these were the central and the right prefrontal electrodes. And these would be the areas for cortical representation of interoception. So fascinating. So these were decreased during the seizure. They also found, so decreased heartbeat evoked potential in areas of interoception, increased sympathetic activity. So then they looked to correlate these, and they found a significant correlation between heart rate variability and the heartbeat evoked potentials, meaning a correlation between a measurement of autonomic activity and a measurement of interoception. Doesn't mean a cause, but they are somehow related. And even what they say in the conclusion is that these possibly represent an electrophysiological hint of how autonomic arousal negatively impacts body awareness in a functional seizure. So, meaning there is this potential, we don't know, chicken or the egg, but does the heightened autonomic arousal actually lower some of the interoceptive awareness in the brain? I don't know, but I find that very interesting to consider. Now, I also want to show you what they found on MRI. So here's figure 4, and what it says, what they looked at was a correlation of cortical thickness with the heartbeat evoked potential amplitude. And they corrected this for many variables as well. And what they found, this particular area of the brain, and I'm going to go back to this in the results, this particular area of the brain, the supramarginal gyrus, had a correlation of cortical thickness in this area to the heartbeat evoked potential. So who cares? Who cares about the supramarginal gyrus? Well, I do. So supramarginal gyrus is kind of this area of the brain. And like most areas of the brain, it has multiple functions, which is, of course, so fascinating. But one of the areas of function in the supramarginal gyrus is sensory integration. So this is an area that integrates multiple realms of sensory information. One of those pieces of sensory information is interoception, right? So again, we don't know cause, we don't know chicken or the egg, but they found a correlation with the thickness of this area, and it was correlated to this amplitude of the heartbeat evoked potential, which was correlated to the autonomic arousal that was occurring during functional seizures. This all of these interconnected pieces just kind of blow my mind. But so let's talk about what does this mean? Because I think we could talk about it on multiple levels. So one of the things is there have been multiple studies looking at what is underlying a functional seizure. This particular study helps to support the idea that there is, here I can stop sharing that there is a one heightened autonomic arousal that they measured via EKG, and there's the potential that this is influencing the person's bodily awareness, their interoceptive processing. This, when when we talk to people with functional seizures, some of the things is that they're not in their body. They're away from their body. They're not connected. They feel foggy. They can't control their body. They don't know what's happening to their body. Those are all interoceptive pieces, right? So potentially this autonomic arousal leads to the reduction in the interoceptive processing, which is really contributing to the experience of the functional seizure. Some of the things that I really think about is we need to be testing and understanding interoception for a person. And particularly when a person has intermittent symptoms or variable symptoms or seizures that seem to happen out of nowhere, interoception and interoceptive awareness might be a piece of that. And improving that outside of when it's happening in the seizure could actually improve the person's control and just their seizure frequency, right? So to me, we need to assess interoception and bring that into treatment. When we think about our sensory treatments, we talk a lot about this. We talk about vibration, we talk about proprioception, we talk about the visual system, the vestibular system, hearing. We talk about all of these things as key components of a person's intervention. Interoception should be a big component of our understanding of those sensory systems as well. So we need to assess it, and then we need to bring it into treatment. And yes, we can actually improve interoceptive abilities. And just like the brilliant comment that somebody had, not only is it improving an interoceptive ability, it's really improving how the brain weights and understands the interoception, how it's amplifying some things and not others, how it's balancing those signals. They're all coming from the body all of the time and mostly without a lot of conscious awareness. So how do we balance that? Maybe you're a person like me. I've talked to people and they'll tell me, I can't, like, my heart is beating and I can't get that sensation out of my head. In fact, I can feel the blood pulsing through my arteries in my head. Those particular interoceptive signals are so high. I kind of think of it like an amplifier. They're amplified so high that the person can barely function or have a conversation with a person because they are experiencing all the blood pulsating through their brain. That's not very helpful, body. That is not super helpful. It might be helpful in some cases, but generally in day-to-day conversations, no. Yeah, as Minnie Moo says, I think you say it exactly like I hear so many people say, I feel my pulse rate in my entire body. Is that very helpful for you? Or is that actually getting in the way of you experiencing other signals? So how can we improve the weighting of those signals? Yes, sometimes you need to feel your pulse rate. Other times not. And usually you don't need to feel it in your entire body. Are there other sensory signals that are getting dampened while that one's getting elevated, right? And how can we help the balancing or the integration or the balance of those things? And this is very individual, right? So not everybody has the same brain or has the same needs sensory wise. This is not about necessarily changing somebody's especially beautiful neurodivergent brain that might be highly in tune with a lot of sensory pieces. So that's not what this is about. This is about finding ways that the person can integrate and modulate some of that sensory information so that they can do the things that they want to do, so that they can go out to eat, so they can read a book without hearing every heartbeat through the arteries in their neck and head, right? So those are the intervention implications. This was not an intervention study, right? So this was not like, okay, we found this and then we intervened, right? So now I would say, after reading this study, if I were in their lab, which, hey, sign me up. I would love to be a consultant with you all. But if I were in their lab, I would say, well, this is very interesting. If autonomic arousal is impairing interoception, maybe we need to actually work on the autonomic arousal piece. How can we change that? Let's give somebody some biofeedback for heart rate variability. We do this all the time. We use something called the LEAF, and it's a heart rate variability monitor that provides biofeedback. So that would be a very simple intervention. I'm not saying that's all you need, but I would start there. If autonomic arousal might be impairing interoception and leading to the experience of the functional seizure, let's work on the autonomic nervous system, right? That might be a way in. We might be able to work on it interoceptively, right? As Heart Content said, it would be great to modulate sensory stuff to function and have fun. That's the holy grail. I couldn't say it better myself. To function and have fun. I don't want to feel every single heartbeat in my whole entire body, right? I want to be able to watch TV. I want to be able to go to a live music performance. I want to be able to go to the beach. I want to be able to walk. Because you know what happens when your body is sensing a lot of this stuff overly? So let's say it's tuned up, it causes other symptoms. You might have tremors, you might have weakness, you might fully have to shut down because you're receiving so much sensory information, right? Yes, as Bella says, the struggles for me, any touch triggers spasms. Yeah, not fun. But that is telling us something about your sensory system, right? Like, it is almost feeling too much, right? So there's a modulation that needs to happen, which I feel like maybe our next live, we should be talking sensory modulation. This study was really about mechanisms. Now, I love mechanistic stuff. In a disorder that's not well understood, like FND and many other things, we have to start with mechanisms. We have to start with what is happening in the brain and body so that we can develop interventions that get to the heart of it. We don't just want to band-aid it, right? So, for example, Bella, we don't just want to wrap you in bubble wrap or put a big, put pillows all around you. Like, that might help momentarily, but it's not actually addressing what is happening in your brain and body. And so these types of studies are getting down to some of the underlying pieces. And it really looks like the research is pointing to the autonomic nervous system and the sensory system when it comes to seizures. And as Heart Content says, knowing the mechanisms is helpful so we can hit the bullseye with our treatment or rehab efforts. Absolutely. Let's stop throwing darts at every single thing and seeing what stick. Let's hit a bullseye. Let's really help people with their symptoms. And Claire is saying, I would love that. My FND patients have very poor interoceptions. They can't feel hunger, thirst, or the need to use the bathroom. Yes. And Claire, thank you for sharing that too. This, by the way, has been shown in the literature, but not across the board. Not every single person, but it has been, and there is an overlap with other disorders. For example, we know that folks with autism may also have similar difficulties with sensing hunger and thirst and things like that. So we might also want to screen for the presence of those things. They're not limited to F and D. Minnie Moo is sharing, I had to shut down the other night because I couldn't watch TV due to the constant tremor, spasms, stiffness, pulsating, lack of concentration. So I went to bed. Yes. So that is exactly why we want to understand some of these pieces so you can get to the bottom of that, so you can watch TV. Because what is that, if your system, if your brain has taken in so much sensory information, what is the option but to shut it down? When it's just so overwhelming. That's all you could do. And you know what? Many kudos to you for recognizing, all I can do here is go to bed. This City Gardens is also saying, I can't watch TV because they flash you every 5 seconds with bright lights for no good reason. Yes. And lots of loud sounds too. And all of those things, again, when you share that with me, I think sensory modulation. There's a visual component of that. There's sound components of that. There's a startle response as well. And all of those things are sensory integration. And to a system that is in a highly aroused state. So again, back to this article, what they found, at least in functional seizures, it'd be interesting to see this with other functional symptoms, was a heightened sympathetic state. In that state, all the sensory information is kind of turned up super loud. It's like you're listening to TV in your house, but it's like the movie theater at Dolby surround sound, like it's shaking your seat, and it's not really, but that's how your brain is bringing that information into you. And Claire is saying too, yes, they both have autism. So I've done a couple of lives before sharing some of that literature linking autism to F&D too. So you'll have to check that out. But part of that link, interoception. Isn't this fascinating? There is so much that I want to talk about with this topic. It was a big part of the FNDS meeting, and I will continue to share. I'll bring my colleagues. So I attended virtually, but my colleagues Chelsea and Ava got to go to Italy in person and attend the conference as well. So much to share about what we're learning and what's continuing to grow in the world of FND in our understanding. It's just pretty amazing, because it means that we can get better and better with treatment, and that there's hope for folks to get better. So again, I'm going to share this video. I'm going to share a link to the article in my newsletter this week. So I send out a newsletter to clinicians. You can sign up at reactiveeducation.com. I send a newsletter to patients or family members, and you can join at reactivept.com or comment newsletter, and I'll send you the link to both of those, and we'll keep talking about it. I hear a great comment, so this is a good, I want to write this down. Her content is saying, I would love more research info on retraining autonomic when breathing is tricky for neurodivergence. I gotta tell you, breathing is hard for a lot of people and is not the only way into the autonomic nervous system. It's a simple way, and it can be very effective for some people, but for a lot of folks, not helpful. So we do talk about this quite a bit. I'm kind of obsessed with some of the autonomic training. So thanks for that comment. We will do more on that. And by the way, if you are a clinician, we just launched that we're doing in-person weekend courses, which I'm so excited about. We're doing one in Baltimore in September. We're doing another at UC Davis in the Sacramento area in October. Baltimore is full, but we're looking to get a larger room so we could get more people in. So that one's sold out, but we have a growing wait list, and the first people on the wait list are the first people in. So join that wait list if you want to join us in Baltimore, or get in on our UC Davis one. That one also has limited spots because they're live in-person courses in rooms that have limited capacity. If you're a clinician, join us live. We're going to practice these things together. We're going to talk about the science, and then we're going to do it. We're going to do it with PT and OT. It's going to be phenomenal. So join us for our live weekend courses. I did hear from a couple folks from Australia and said, we can't come. So first of all, you should invite me to Australia and I will come. But actually, we have two online courses for you. So if you're out of the area, if you're a clinician, we have a mini course that is 2 hours long, and we have a whole self-paced course on F&D, on CRPS and dystonia, where we dive into each piece of the pie. This is our complex case masterclass. So I shared those earlier on our stories, but you can go to reactiveeducation.com and look at our courses. So if you're looking to dive deeper in F&D, we have two online courses for you if you can't join us in person for our weekend courses. These courses are for clinicians, and I'm just so excited to see you all in person. And then finally, if you're a person with FND, we have several options to work with Reactive. And one of the easiest ways is to join our FND membership. So we have a membership where we've got an online community that's private. It's off of social media. We have education that is recorded and available about all of these topics, by the way. And we have online classes. So we have an F&D education class every week. We have a dysautonomia exercise class every week. We have a yoga class for people with F&D led by our amazing OTs. We have exercise classes. We have a mind-body class led by one of our psychology team. It is amazing. And you can join us month to month, or you can join us for a year. So that's our F&D membership. So if you're a person with F&D and looking to get connected in some way to Reactive, that's a great way. And then of course we do our intensive programs at our California locations, and you can check those out at reactivept.com/FND. So I just wanted to give you options to stay connected to us, and keep the questions and great comments coming. I love hearing from you, and I will see you next time. Have a good night.